why someone would need to or have to stop TRT, and would it be indefinitely, or could they then start up again? So what have you come across in practice for why someone would want to stop their TRT? Welcome to another video with Balance My Hormones and Dr. George Touliatos. This is our doctor's question time. Today's topic will be reasons for stopping TRT. Why would you want to stop TRT? Do you need to stop TRT? So George, welcome.
So if we take a look before starting TRT, the contradictions about it, there are mainly erythrocytosis and benign prostatic hypertrophy, not prostate cancer, okay? So an elevated PSA over 4, for instance 5, and free PSA also, but also hemoglobin over 18 and hematocrit over 54. Now, some people are more prone to elevated hematocrit as myself, which is genetically predisposed, of course, and the same applies for some people that they have this genetic predisposition. Their dad maybe died of prostatic cancer, so they have already an elevated PSA. Of course, we have to know that PSA is elevated either from sexual intercourse, from biopsy for excessive bicycle, and cycling. So if we are into testosterone replacement therapy, and then even though you perform donations every 3 or 4 months, or even sometimes every 2 months, then you realize that your hematocrit elevates, and then you have to use some aspirin, pentoxifylline, some fish oil. Some people also speculate that grapefruit juice and arginine also helps to lower your hematocrit and erythropoiesis. They have to stop testosterone replacement therapy for a while in order to stop this exogenous stimulus, which is androgens that stimulate erythropoietin. However, it's not just the androgens that stimulate the erythropoietin, which is secondary erythrocytosis, but also the hypoxia. Hypoxia now takes place under obstructive sleep apnea and snoring, which is a major stimulus for low oxygen saturation that kicks the kidneys for EPO and then the bone marrow for erythrocytes production. All right, so you have 2 factors, the androgens and the low oxygen saturation. Of course, smoking is contradicted because it's also elevated, and living in high altitude as well.
So, but people in high, sorry, George, people in high altitudes, they're not required to give blood, and are they not able to go on TRT because they're already having high?
It's different when you're born in high altitude, and then you get accustomed and you get used to this, and other people that live, for instance, for a brief period of time, from sea level going to 2,000 meters high, for instance.
You mean who are training specifically?
Yes. So in first place, they get adapted, and then there's no such a medical issue. But unlike some endurance athletes that prefer to train up, to live upwards, and then in high levels, and then to train in sea level with elevated hemoglobin,
Sorry to interrupt, but if those people could get adapted to it, why could you not be adapted on your TRT over the years of having high? I mean, are we sure that elevated hematocrit and hemoglobin erythro?
Yeah, this is a good point that we also
harmful.
Yes, this is a good point that we also discussed in the previous videos with Sam also. But what concerns me most of elevated hemoglobin is about viscosity, the thickening of the blood, but also other factors come into play, which is blood pressure, insulin resistance, atherosclerosis, endothelial disruption. So it doesn't mean that necessarily if you have a hemoglobin of 20 that you're gonna die out of a stroke in first place. There are other factors.
So you're saying, as a doctor, it's just being a little bit extra cautious with some patients, but trying to balance it out without creating unnecessary fear. So you have to take every case individually. Looking at other factors.
Sure. Yeah. Well, the standards say that over 18 and 54, because it's 3 times your hemoglobin hematocrit, you're supposed to be considered as ill. So you donate because your blood cannot be transfused to somebody else because of the high viscosity. It's very viscous and thick, And then if your hemoglobin is 17 and 51 hematocrit, then you're considered as a healthy individual in order to blood donate, and not get phlebotomized, which is wasted afterwards. They're throwing away the blood. personally, when I was attending to the Red Cross, they asked me, "What's wrong with you in your eye?" You know, and I was telling that maybe I was smoking and was living in high altitude. You know, of course, they had no clue about the androgens I was using. And yes, generally the people they have to suffer from polycythemia vera in order to have such elevated hematocrit. Otherwise, if you're not using testosterone, then I remember myself when I was not using steroids for 6 months, my hemoglobin was about 15 to 16. So my hematocrit was just raising below 50, which is actually high for a natural guy, but still you don't expect high levels. So I guess that there has to be a stimulus, either OSA, obstructive sleep apnea, smoking, and of course androgen use.
Okay, so I guess you have to be very careful before you take someone off their TRT treatment.
Yes, I'm sorry, I forgot to mention that cutting off the substrates for hemoglobin synthesis, which is iron plus ascorbic acid, cobalamin, B12, and folic acid. So practically skipping red meat consumption, it might help you not to reach such high hemoglobin levels if you are prone to it. Right. So in my case, I eat fish and white meat in order to avoid getting excess of B12, folic acid, and iron that will synthesize easier hemoglobin.
So with some of your patients, then you may have them trial things like reducing their red meat consumption, making sure they don't have any iron supplements, but you'd also have them look into getting treated potentially for obstructive sleep apnea, right?
Yes,
so you can get
yes.
Yeah, that's what
dropping in weight, because also the thicker your neck is, then there's an obstruction of the upper pathways, you know, and then there becomes a turbulence and you snore, and then you have this kind of hypoxia. But also, in order to distinguish from polycythemia vera from erythrocytosis, because in polycythemia vera also you have elevated thrombocytes, which is platelets, you have to distinguish erythropoietin levels. So in polycythemia vera, erythropoietin is very low. It's about 1, lower than 2. Now the lowest levels are 4. Mine was 7. So when I was consulted by the hematologist, he told me that you don't have polycythemia vera, not only because your platelets are low, 150,000, but also because your hemoglobin is up to 7, 4 to 30 are the ranges. So if you had vera, it should be down to 1, your EPO. So you're excluded, you don't need hydroxyurea, you just need to stop TRT for a while, and also stop other androgens such as proviron, DHEA, and pregnenolone that may also stimulate some of the erythropoiesis.
So for a while, essentially doing washouts. So I've heard of some doctors doing that in the United States as well from time to time. So that's kind of an interesting option.
And frequent donations may have a rebound effect and further stimulate EPO because bone marrow, because the system senses kind of anemia and low ferritin and low iron levels. So it has to kick back with further production of erythrocytes in order to counterbalance this loss of the blood after frequent phlebotomies.
The therapeutic phlebotomy, to the range that they would, in the way they would do it for someone with polycythemia, would be counterproductive in someone with erythrocytosis.
It is very frequent, less than 2 months, because the half-life of the erythrocytes are 90 to 120 days, so roughly 3 to 4 months. Now, if you perform it frequently every 2 months, then you're going to have the negative effect and will further kick your EPO.
I believe I read that the average person who's donating to like the Red Cross or the NHS blood donation service for a man, at least according to this, who can give blood through the NHS blood service, for a man every 12 weeks, and a woman can give blood every 16 weeks. So that's
every 12 weeks is 90 days. So it's
3 months,
yes. To be honest with you, my last 3 donations were every 2 months.
Okay, so
I guess it had a negative feedback.
So that wasn't beneficial. I suppose the other things you're doing with the fish oils, that was helping, and maybe a slight, for you anyway, a slight break from TRT, or even a reduction of TRT. I mean, one of the other things we spoke about was the trough level being a predictor for your erythrocytosis or your hematocrit and hemoglobin. There were some papers that were pulled up about you know, how high your trough level is before the next injection. So if you could talk about that a little bit, what your thoughts are. Have you seen any?
Your what? Your trough?
So the lowest, so when you do, let's say you're injecting every 3 days, as long as your free testosterone isn't in the supraphysiological range.
Free testosterone is responsible for E2 production. DHT is the real deal that spikes.
But it can also spike. So according to this one paper, your free testosterone level, calculated free testosterone, was a predictor for erythrocytosis.
Yes, because it's not the total testosterone that it's affected, it's the free testosterone that if it spikes, and how it spikes with shooting once a week, for instance, then it gets affected, higher estradiol, higher DHT, and that erythrocytosis also is DHT induced. So by shooting smaller doses every day, for instance, very frequent doses, then you diminish your spike in free testosterone that has an effect in the other two factors.
But it could also be that, so you know, if you look at the traditional treatments, and not that this is being advocated, but you know, if you go to the package leaflets, it's every 2 weeks for the injection, and you get a really super physiological level followed by a big drop off. Do people who get the every 2 week injection, are they as prone to erythrocytosis? Because that low level for 3 or 4 days in the trough is it reducing the amount? Is it just the peak? Or are you injecting too frequently? Therefore, your free testosterone level is constantly really, really high.
Now listen, if you inject frequently, you obviously inject smaller doses.
You would hope so, but if you're, I don't know. I'm just throwing that out there.
I'm telling you, to shoot either 100 milligrams on Monday or to shoot 25 milligrams 4 times a week, every other day. It's totally different result. And think about the other one thing. Why Nebido is blamed for spiking hemoglobin? Because you shoot 1,000 milligrams, and this is tremendous, the result in free testosterone. And why transdermal testosterone is not blamed such as injectable at erythrocytosis? Because you apply every day small doses.
So I think what you're saying is the dose has to be right. So if you inject every day and the dose is too high, you'll get erythrocytosis.
Oh, of course, come on. 250 like Ronnie Coleman was using 1 gram every day.
So he's doing frequent dosing, but it's not.
Yeah.
So I guess people have to be careful with the dose amount. So doing frequent doses is really doing more frequent dosing. Okay.
You divide your total dose in smaller ones. Okay, you don't take your weekly dose every day.
Okay. Anything else that we want to cover for reasons for?
About the prostate, I had to tell about the prostate. Now, I have to tell you that I had an argument and a conflict with a urologist, a famous urologist from Cyprus, in a Greek conference. That he told me, Dr. Touliatos, are you sure you can proceed with testosterone replacement therapy after prostatectomy due to prostate cancer? I said, yes. Read about and listen about the saturation receptor therapy of Dr. Abraham Mogitaler in Harvard. And of course, obviously, this doctor was not using testosterone itself. You know, he was just going by the book. You know, and actually, he's very notorious for doing injections in the penis for electric action. But obviously, this does not affect your libido, your sex drive. It's just a blood flow. You know, an artificial blood flow. That doesn't mean that you want to have sex.
So you're talking about the aloprostadil and the PG1.
Yes. Injecting now with an insulin syringe on your dick before you're having sex, you know.
Yeah, that's what the porn stars do.
Yeah.
Yeah, the porno stars do those injections.
Really?
Yeah, well, you know, if you get stage fright, what are you going to do? So you.
Well, I thought we were using androgens along with PEDs. With
well,
PED.
yeah, but if you get a surge of adrenaline or vasoconstriction, you need to have something that's going to override your.
Yeah, if you sniff cocaine, actually, it's going to lead to peripheral vasoconstriction. Yes.
So I mean, the penis and erection is all about the vasodilation. So.
Yes. I had to tell about the prostate now. Mogitaler believes that if your PSA is over 4, then just perform a biopsy. That's all, because with biopsy you see just within the gland and the cells and the any kind of proliferation, you know. So biopsy tells you the truth, and then you avoid the digital rectal examination or the MRI, you know. in case you have elevated PSA and symptoms of an elevated
So
benign hypertrophy.
wait, so you're saying do a biopsy instead?
Yeah, in case within TRT your PSA is over 4, then just perform a biopsy and that's all.
Well, hang on a minute. A biopsy isn't just, oh, just do a biopsy. There's a risk of serious infection if you do a biopsy.
Listen, okay, of course with sterilization, it's like a surgery, but you have to know that biopsy itself elevates PSA, you know, the puncture of the gland. But in order to estimate what's happening inside, if there's any malignant or benign hypertrophy, you know, then biopsy tells the truth. As a matter of fact, I had 2 55-year-old guys with elevated PSA, and they performed a biopsy, was negative, and then they proceed also after with testosterone replacement.
Okay, what about an MRI over a biopsy?
Well, MRI tells the truth also, but of course, nothing beats a biopsy because you just read the cells inside, you know. The MRI also is more effective than the digital rectal examination, the pelvic MRI, okay?
I mean, but there's a new procedure, actually. It uses a blood test, and this blood test, I think it's been developed near Oxford, or maybe Cambridge in the UK here, where they look at actual malignant cells in the blood to see.
Listen, there are the tumor markers of CA 19.9 that predicts some inflammation and cancerous cells. CA 19.9 and also CEA and alpha fetoprotein. These are the 3 tumor markers apart from the.
Well, this is a new one where they're actually looking at malignant cells that they can discover in the blood. However, they say it's not for diagnostic uses yet. They're still waiting for approval. But this may be something in future that we might have as an option that would actually tell us you'd have a higher PSA, and then you can also look at the actual cells that are found in the blood. Anyway, I guess I have to watch.
But of course, prostatitis also may elevate PSA, you know. So it doesn't mean, of course, that something, the gland is elevated itself from the androgens or the DHT elevation, but also by taking antibiotics under prostatitis will lower PSA.
Right, so prostatitis may be another cause.
A very common cause of prostatitis is anal sex without a condom, you know. You get Escherichia coli back to your urethra and then to the prostate. So a practical way is to pee to urine after your anal sex, you know, in case you don't use condom, in order to flush away all the anal bacteria, you know, that may lead you to prostatitis.
Of course, all right, that's a good plan. But you know, all these things can be very stressful for a patient, right? So I think the last thing a patient wants to do who's been put on TRT is to want to come off. I mean, for most men,
I believe they in order to manage erythrocytosis, okay, 8-week stop would be enough. And also, for instance, 1 month in order to measure out what's going on with your prostate. So I don't think it's just postponing for a while your replacement therapy. Cutting off, yes. I mean, reasons for not for quitting, but stopping for a while and examining the factors. Okay.
What about? I don't know if you've seen this in some maybe younger men who will go on TRT in their 20s, start getting their life improved, and then say, yeah, maybe all my exercise, proper sleep, diet has led me to feeling better, so maybe I can stop the testosterone treatment. Have you seen this in practice, where then guys say, well, hey, can I just stop my testosterone treatment now because I think everything's better? And what we found, people just call us back in 3 to 4 months later saying, well, actually, I do need my testosterone.
Of course, because when you are plagued with testosterone, then your own production shuts off, and then you get out of fuel, you know, when you stop using testosterone, because it is a homeostasis with every hormone, thyroid hormones, cortisol, androgens. You shut off your own production, and then there is a horrible rebound, you know.
But eventually they go back to maybe where they started, but they still don't feel as good as they did.
It matters the age, also the time of the abuse.
But we're talking just normal young men who get put on TRT. We're not talking abuse. That they think, well, okay, my life's turned around now. Things are better. My exercise, my diet's there. I think I'm going to stop.
That's why I'm asking and I'm telling them HRT is not a trendy thing, but it's a lifetime treatment for somebody who is hypogonadic. So it's not something to get jacked for a couple of, you don't on and off this.
But that may not have been their intention. Their intention was, oh, I'll get better. So do you think maybe for some of these, maybe younger people, maybe it's buyer's remorse, or maybe they didn't realize that they weren't committed to staying on it?
They have not already decided very maturely. So it's like some people would want to do a tattoo and they have not decided what to ink, and later they regret it. So it's a lifetime decision. That actually it's a treatment of a disease. You know, just about, I tell them, if you want to get jacked, do a steroid cycle and then do a PCT. But eventually you get your end to TRT, but you cannot use for life something if you don't need it and later regret of this. No.
Yeah. So I guess there is some guilt built into some guys, or the hope. I think it's a hope for a lot of people that they don't have to depend on something.
Yes,
to feel better.
It's a commitment. It's a lifetime commitment. You know, the discipline, and also the lifestyle. You cannot just use testosterone and eat junk, you know, and expect them to be optimized and have effects.
Yeah, like my friend the psychiatrist would say, testosterone and donuts don't mix.
Yeah, of course.
So, you know, I've been on TRT for about 24 years, and I think I'm in the opposite spectrum where...
Are you tired of that?
No. I mean, I say, oh, what's today? Today's injection day. Oh,
okay, well, listen, back in your 20s, you thought, oh, I'm going to do it for the rest of my life?
I was in my 20s. Well, there was a time in my early 20s where I was a little bit concerned, but I realized how terrible I felt trying to recover on my own, you know, seeking out other doctors. Some of the doctors made me feel like some sort of criminal for looking to maintain better levels. I just didn't feel good anymore until I finally found the doctor in California who put me on testo cream, and then from there eventually got on injections, etc. But
the same goes for thyroid patients, but you know, taking your thyroid meds is much easier than injecting yourself.
True. So maybe it's the method of either application, either your creams or your injection. Maybe there's this taboo in society. Oh, needles, injections, you must be a junkie. So sometimes this might grate on people's psyche. I mean, that's why we make these videos. It's for, you know, both our clients and our friends of Balance My Hormones and other people in the TRT community.
We don't want to dogmatize. We don't want to stigmatize. Okay, and we don't like labels.
No, exactly. And it's good to get your opinion as a doctor, a well-known doctor in the community, to see what your thoughts are. That's exactly why we're here. So these are things that can help. So, all right, well, that's this episode of Balance My Hormones with Dr. George Tiliatos, talking about reasons why you may consider stopping TRT. So thanks for watching, and we hope you subscribe to our channel and press a like if you do like the video. Please leave your comments for different videos that you'd like to see or different topics you'd like us to talk about, and we'll be back for the next episode shortly. So thanks again. Thanks, George, and we'll see you all next time on Question Time with Dr. T.